meneruskan dengan ceramah ketiga yang akan disampaikan oleh Dr. Kamalia binti Kamarulzaman.
A brief biography of Dr. Kamalia. Dr. Kamalia is a nuclear medicine physician from Hospital Kuala Lumpur with a special interest in neuroimaging. She completed her fellowship training in nuclear neurology at Asan Medical Center, South Korea in 2020. She is actively involved in imaging of various neurological diseases, including movement disorders, dementia, epilepsy, encephalitis, and many more. Please put your hands together to welcome Dr. Kamalia binti Kamarulzaman to give a talk on PET-CT abnormalities in neurodegenerative disorders. Assalamualaikum everyone. Okay, good morning and welcome to my presentation. So after 2 lectures this morning, so maybe you all can do some stretching dekat tempat masing-masing, okay? Just to refresh lah. Okay, so thank you, Mr. Introduction. At the same time, I would like to thank the organizing committee for inviting me here. So, my voice is clear? Okay, so it's an honor for me to share with all of you on the PET-CT abnormalities in neurodegenerative disorder. So I'm Dr. Kamalia from Hospital Kuala Lumpur. Okay, so I'm sure most of you recognize these people, right? So, so actually, anyone knows what do they have in common? Yeah, so they have actually been diagnosed with different kind of neurodegenerative disorder. For example, late Muhammad Ali and Michael Fox were diagnosed with Parkinson's disease, and while the late 40th president of US, Ronald Reagan, was diagnosed with Alzheimer's disease, and this is Robin Williams, who died of dementia of Lewy body, and recently diagnosed frontotemporal dementia, Bruce Willis. So it's very common actually in our population. Okay. So for today, I will brief through the characteristic properties of CNS tracer imaging and its application in the commonly encountered neurological disease in the clinical practice, which are dementia and Parkinsonian disease. So my topic for today basically concentrate on the nuclear medicine imaging. So just now, Dr. Afida already talked about the MRI, the anatomical function, anatomical imaging, and now I'm talking about the nuclear role in the neurodegenerative dementia. So specific for tracer imaging, because you know nuclear medicine, we always play with tracer, right? So what is it very important for us to choose? Which one to choose for the tracer? So first, it should be able to cross the blood-brain barrier. As you know, blood-brain barrier is a very tight region. So we need to choose a specific tracer to be able to image the brain. And then must be not being able to being a P glycoprotein substrate. And then it should have high affinity and selective for the target. It should have high suitable pharmacokinetics. It should have suitable pharmacokinetics for imaging and favorable dosimetry. And it should have lack of radioactive metabolite that cross the blood-brain barrier. Moving on to my first topic. So for today, I will concentrate on 2, dementia as well as movement disorder. Right. So for my first topic, we are going through the dementia using F18 FEG. So for dementia, these are the example of most commonly used PET radiopharmaceutical, which are FDG and F18 florbetaben. So I will so both have different localizing mechanism, and extra usage for F18 FDG. It can also be used in tumor, epilepsy, and differential of Parkinsonian syndrome. So dementia. So what is dementia? Is defined as a decline in cognition significant enough to interfere in daily functioning. So it incur a high cost, especially in US. They have data. They spent about 818 billion in 2005 just for the diagnosis, for the working diagnosis, for the treatment. So the global prevalence of approximately 7% in those over 60 years of age, and a prevalence of nearly 15% in the US in those over 68 years of age. So it's very common. 1 in 5 residents in US is projected to be over 65 years of age by 2030. So you can imagine the case will increase. So as for the diagnosis, the common one will be the Alzheimer's disease, as mentioned by Dr. Afida. in her earlier stage, earlier talk, followed by vascular dementia, dementia with the body, and frontotemporal dementia. And less than 1% of other dementia will fall outside of this category. So why is it important for us to know whether this is Alzheimer, frontotemporal dementia, dementia of the body? It's not just for the diagnosis sake. It's actually as an implication on to choose appropriate treatment to facilitate early non-pharmacological intervention, to reduce overall healthcare costs, because we need to, we try to minimize the cost of getting into the diagnosis, and we can able to provide the families with prognostication for anticipated clinical costs. Okay. So, so this is my bread and butter lah, F18 FDG PET. Okay. So prior to this is the acquisition and how are we doing this PET imaging. So prior to imaging, usually patient will fast for at least 4 hours to allow the optimal cerebral uptake, and then patient should fast for at least 4 hours to allow optimal cerebral FDG uptake. And then patient should be advised to avoid the excessive stimulants which may affect the brain metabolism. And drink coffee, cola should also be avoided, as well as smoking and excessive exercise. And then injection will be given about 150 megabecquerel. Waiting time is about 30 minutes before proceed with image acquisition. Okay, sorry for the technical glitch. Right. So for better visualization of brain segmentation and symmetricality, so it's very important for us to align the brain in the commissural line. So before reporting your brain, for brain reporting, you must make sure that you put your the axis line must be in correct order. For example, it should be in the anterior and posterior commissural line, and for the temporal visualization, it should be in the temporal long axis. Okay, so this is a normal FDG uptake, which it should have a higher striatum and thalamus uptake as compared to cerebral and cerebellar. Okay, so this is a top-down approach to interpretation of FDG PET for dementia by Sawyer et al. So FDG does not bind to any pathologic protein, so it requires that the reader recognize the characteristic pattern of glucose hypometabolism to identify the pathology. So this approach presents an algorithm for organizing the finding and systematically applying them to interpret the FDG PET. So for example, the analysis begins with the evaluation of the parietal lobe. Okay, if it's normal, then the evaluation of the frontal and temporal lobe should follow via pathway A. Okay. And then the analysis begin with the, if normal, is decreased, then it should lead to the pathway B, where the precuneus and temporal lobe are evaluated. So if the precuneus are normal, so then non-neurodegenerative causes should be considered, such as vascular dementia, depression, drug-induced. Okay, if there is hypometabolism of bilateral precuneus or temporal lobe, then the Alzheimer disease, dementia of the body, and his posterior cortical atrophy, this may lead to these three differential diagnoses. So which can be further divided into according to the pathway C, right? So we have some of this approach how to interpret activity. So we don't simply like looking everywhere. We must zoom onto the specific area and then we go accordingly. Okay, these are the differential diagnoses of neurodegenerative dementing disorder by FDG-PET. So the major dementia can be divided into Alzheimer disease, frontotemporal dementia, and dementia of the body, as I mentioned earlier. FTD can be further divided into the behavioral variant of fixed disease, PPA and movement disorder. PPA can be further divided into the semantic, non-fluent, and locogenic variant. And movement disorder type of FTD can be further divided into progressive supranuclear palsy and CBD. So it is very important for us to sort of know how they divide into the classification, because this might help you in terms of your interpretation later. I will show some of the cases. Okay, so sorry for it's quite small, the font. So basically, this is to understand different type of dementia. So for Alzheimer disease, the pathology is basically in the due to the abnormal deposit of protein from amyloid, plaque, and tau tangled throughout the brain. For FTD, there is abnormal amount of form of tau and TDP-43 protein in the frontal and temporal lobes. Okay, for dementia of Lewy body, because the name is Lewy body, so basically it's a deposit of the alpha-synuclein called as Lewy body in the brain, which affect the brain chemical messenger. And vascular dementia is caused by the disruption of the blood flow. So symptoms can be similar among different type of dementia, and some people can have more than one dementia, so which result in difficulty in making the accurate diagnosis. So usually clinically we are having difficulty whether this is whether it's Alzheimer disease or whether or is it frontotemporal dementia. Okay, so our by doing anatomical and functional imaging, when we combine both two, so perhaps we can come into the final diagnosis. Okay. So despite this difficulty, it's very crucial because, like I mentioned before, in terms of prognostication and family counseling. Right. Different type of neurodegenerative disorder tend to affect specific brain region, which is called as selective vulnerability, while sparing other region. So the severity of FDG hypometabolism also correlates with the duration of the disease. Okay. So the special pattern of decrease versus relatively preserved FDG uptake in the brain give differential clues to the specific neurodegenerative substrate. So for example, in Alzheimer disease, the FDG hypometabolism or the selective vulnerability is seen in the temporoparietal association cortex and also the posterior cingulate. Okay, so this region is very important, posterior cingulate and precuneus. Okay, the LBD caused by it has a hypometabolism of the occipital, so with preservation of the cingulate, so this one will give rise to cingulate island sign. And frontotemporal dementia, as the name implies, is actually caused by the hypometabolism will affect the frontal and temporal lobe. Okay, I will let's go through some of the dementia cases being referred to HKL. So case 1, 40-year-old lady with 2 years history of forgetfulness and strong family history of young onset dementia. MMSE is moderately reduced with normal CSF. Okay, MRI showed generalized cerebral volume loss, most notable in pericerebral region and commensurate volume loss of both hippocampal formation. FDG showed significant hypometabolism of the temporoparietal and posterior cingulate as well as precuneus. There is also hypometabolism of the frontal cortex, and this finding is very typical of Alzheimer's disease. Right. Second case, 35-year-old man presented with 5 years history of behavioral changes worsened for the past 6 months, associated with personality changes and decreased interaction, disinhibition and forgetfulness. MMSE was severely reduced. Other investigations, CSF, MRA, MRV, EEG were normal. So MRI showed cerebral atrophy with no focal lesion. But our FDG showed marked hypometabolism of bilateral frontotemporal, which is more marked on the left side. So this is very consistent with frontotemporal dementia. A 59-year-old female, 3 years history of progressive memory loss and loss of executive function, language and speech impairment. MMSE is moderately reduced. MRI, scattered gliosis and small vessel ischemia involving both frontotemporal parietal and periventricular with medial temporal atrophy. But the FDG, okay, as you see the FDG, it showed hypometabolism of bilateral frontotemporal parietal, precuneus, and posterior cingulate. So this finding is suggestive of a frontotemporal, can be frontotemporal dementia, or because of the involvement of the precuneus and posterior cingulate, it can still represent a frontal variant of Alzheimer's disease. So this one we cannot conclude whether it's FTD or it's Alzheimer's disease. So this is when your amyloid scan plays a role. So you can differentiate FTD and AD. All right. So based on the history, it still can be both. Okay, my last of dementia case, 59-year-old female, 5 years history of behavioral changes worsening for the past 6 months. She has also mood changes with depression and also irritability. However, the cognitive function, the memory and language is normal. MMSE also fairly normal. MRI showed generalized brain atrophy with prominent atrophy of bilateral superior parietal lobules and mild atrophy of bilateral hippocampal formation. FDG showed a very mild hypometabolism of bilateral frontoparietal with preservation of the posterior cingulate and precuneus. So FDG finding is actually suggestive of non-neurodegenerative, which are likely due to the depression. Okay, now we finish with FDG-PET. Now move on to the F18 floor beta band, which is amyloid scan used in dementia. Extracellular amyloid beta aggregates are the key pathologic hallmark of Alzheimer's disease. Aggregation of amyloid is a slow and protracted process which may extend for more than 2 decades before the onset of clinical symptoms. Floor beta band is an established biomarker of amyloid deposition, and visual assessment of F18 floor beta band PET is used in the clinical setting to estimate the amyloid neuritic plaque density and to classify scan as positive or negative. So just now FDG, they are looking at the glucose metabolism. So this one is looking at the amyloid deposition. Okay, so when to use amyloid? Okay. So in the case of persistent or progressive unexplained MCI, or the one with unclear presentation, or the one with present with atypically early age of onset, usually defined as 65 years of age. So if you notice, 4 of my patients just now when I presented, all of them are actually below 65-year-old. They are young, 35, 39, 59, right? But since we don't have this amyloid imaging at the moment, okay, yet. But in this below case, it's not appropriate to use. For example, patient already is already like present typically with probable AD, so you don't have to do to determine the dementia severity. Also, you don't have to do patient with family history, so it's not appropriate to do. Or patient in for non-medical use, legal insurance coverage or employment also is appropriate to use. Okay, these are the fluorinated traces used for amyloid PET imaging. It shows high uptake in the white matter as compared to gray matter, and the typical negative. So you can see on your negative, there will be a preservation of the gray white matter differentiation, and for positive study there is loss of gray white matter differentiation. So these are the choices that we can use for the amyloid imaging. We can use flow beta band, flow beta pair, or protimetamol. And this table shows the different type of amyloid imaging with its recommended activity, waiting time post-injection, and its acquisition time. So amyloid imaging is you need to have usually an experienced eye for you to diagnose usually. But the diagnosis will be a binary outcome, whether negative or positive. Okay, so for F18 flow beta band, basically there is no specific dietary advice, not like MDG just now. So injection is about 8 MCI. Patient has to wait for 90 minutes, and then before proceed with its PET-CT acquisition for another 20 minutes. Okay. Amyloid imaging using F18 flow beta band provide more accurate interpretation of amyloid deposition because it encompasses of the qualitative as well as semi-quantitative analysis. Okay, with the semi-quantitative analysis, they have a specific scoring for it, which is a Bumper and also RCTU score, which gives rise to a binary outcome. So basically, the assessment is quite simple because it's just based on the PET-only images in axial orientation in grayscale. So you just have to use that. And then we just focus on the white and gray matter anatomy. And these are the 4 regions that should be concentrated on: lateral temporal lobe, frontal lobe, posterior cingulate, and also parietal lobe. So so on this 4 regions, we must be able to identify the normal and abnormal sign. Okay. These are the typical imaging pattern for common neurodegenerative dementia. Okay. So just want to highlight to you, like for example, Alzheimer's disease and dementia with Lewy body, there will be a positive finding in FDG and as well as amyloid PET. Okay, so this figure shows different type of imaging which using MRI. Okay, the second image is the qualitative FDG. The third and fourth line is basically representing the 3D SSP and Z score, and the final line representing the amyloid PET. So, for example, in a normal 80-year-old lady, MRI usually showed a cortical atrophy, 80 years old, white matter disease. But when you do FDG, will be normal, and also the amyloid will be negative. Okay, and then the second case, you can see a 56-year-old gentleman with Alzheimer's disease. The MRI usually showed a generalized cerebral volume loss with volume loss involving the hippocampal, and the FDG usually shows decreased bilateral frontotemporal parietal, especially the precuneus and posterior cingulate, and also positive amyloid. Okay, the below line is amyloid, so you can see there is loss of gray-white matter differentiation, and also in diffuse with Lewy body, 63-year-old, usually FDG will show decreased bilateral fronto-posterior temporoparietal and occipital. So you can appreciate the cingulate island sign. That is the only area that highlighted. Okay, the cingulate region, and with positive amyloid. So I touch a bit on this pathophysiology so that you will know why you want to choose FDG, why you want to choose MRI or other imaging. Okay, so FDG and amyloid PET are used as a biomarker to detect or diagnose AD in the pre-symptomatic state. So if you see this line in the pre-symptomatic phase, you already got the amyloid. You can already got a positive imaging in amyloid scan and also in your CSF. Okay, so actually this is a model of dynamic biomarker of Alzheimer's disease and a pathological cascade. Okay, so the complexity, when is the complexity of dementia arise? It is actually when we want to know what is the etiology to allow for the best treatment. Okay, so as you can see, for the PET, be it a amyloid or FDG PET, it can help to achieve an accurate diagnosis much earlier in the clinical course of the disease compared to the conventional structure sequence. So based on this graph, we can also appreciate that you can see the first one in the pre-symptomatic. Okay, pre-symptomatic amyloid biomarker become first, become abnormal first, and then followed with biomarker of neurodegeneration, which is FDG. Then only prior to the clinical onset. So in the full-blown dementia, actually we can detect earlier on already in the PET-CT. Okay, so beta amyloid actually it actually precedes the clinical symptomatology by up to 20 years, although it approached a plateau over time. So, but for FDG, it tracks more closely with the progressive cognitive impairment. So, imaging also can help to avoid more invasive investigations such as lumbar puncture. If you notice just now, all my 4 patients, they did CSF. So, they have to do lumbar puncture for the patient. So, it's invasive, and also it can also avoid side effect, headache, pain, bleeding, infection. Okay. So by being more conclusive at earlier stage, PET can lead to reduction in number of additional and serial investigation, hence reducing the time and also cost to come to the final diagnosis. Okay, so for dementia, we also, they have this Maureen et al. They propose an imaging algorithm incorporating the nuclear medicine imaging in managing differential type of dementia. So if you can, as you can appreciate from this figure, you can see that we should consider a functional imaging if there is none of equivocal structural changes, because nuclear medicine center is not available. I understand that sometimes it's not available it is usually not available in every hospital. So it's very regional. So the easiest thing that you can do is send for patient for anatomical imaging. Then if you are not sure it's equivocal or patient with young dementia or multiple pathologies, then you can consider doing DAT scan or amyloid imaging. But now we don't have the amyloid imaging, but we do have DAT scan, TRODAT, and also you can send for FDG based on the differential diagnosis suspected clinically. Okay, my second topic will be on movement disorder for Parkinson's disease. So usually clinically, it will the diagnosis will be based on the clinical features. You see the associated exclusionary symptom and the response to levodopa. So the clinical diagnostic accuracy made by a qualified neurologist was 65% at initial and 76% after 12 years of follow-up in pathologically proven cases. So there are 2 main pathological hallmarks of PD, which are loss of dopaminergic neuron in the substantia nigra and the presence of Lewy body. So despite knowing the typical presentation of PD, but usually when you encounter the case clinically, it's actually a complex disease and hard to diagnose clinically, especially in the early stage, whereby there are many overlapping clinical features with less sensitive diagnostic criteria. About 10% of patients are misdiagnosed, PD patients are misdiagnosed, and up to 20% have alternative diagnosis at autopsy. So why is it important? Okay, same like dementia, you need to know you need to know the etiology. For Parkinson, for movement disorder also, you need to know the differential diagnosis because you want to for the treatment strategy and for the prognostication. So why is it functional imaging? Because it's difficult to reliably establish a diagnosis clinically, and most of them usually they will go for postmortem study. Structural imaging is often inconclusive, especially in the earlier stage. So assessment of the dopaminergic system with SPECT and PET is a specific approach to address the pathology of the nigrostriatal dopaminergic system and also in the preclinical phase of some of these diseases. Okay, so this table showed clinical differentiating of Parkinsonian disorder. So when you plug a patient, there are certain symptoms or signs that you should be able to pick up and ask the patient. So it will help for you to zoom in what type of the movement disorder that patient has. So for example, in MSE and PSP, the symptom is usually symmetry as compared to PD. And for PSP, there will be axial rigidity, postural instability, vertical gaze restriction, and frontal behavior. CBD usually present with limb dystonia or alien limb, and MSA usually patient have autonomic symptom. And PD usually shows good response in the early as well as late stage to the levodopa as compared to atypical PD. Okay, so this is the pathophysiology. Why you want to choose a specific radio tracer and why you want to choose it. So basically there are pathophysiology behind it. So in atypical PD, the degeneration occurs at the level of pre and post synaptic. Okay, while in PD, usually in PD, the postsynaptic dopaminergic function is intact. Okay, so these are the available radio tracer in for the in vivo imaging. So for presynaptic transporter imaging, currently in HKL we have TrueDAT, but unfortunately none of the postsynaptic dopaminergic imaging are actually available in Malaysia. So with this understanding, we know that it is impossible for us to differentiate PD and atypical PD just by doing TrueDAT. Okay, we cannot differentiate. So fortunately, we can use other molecular target to differentiate PD from atypical PD. So you can use everything FDG, or you can use your iodine 131 MFDG, which is also available in HKL. So this figure shows differential diagnosis between PD and atypical PD at pre and post synaptic level. So you can see that the presynaptic imaging, the control will be normal finding, but abnormal in all three types of movement disorder. But by doing the post-synaptic imaging, you can differentiate the PD. In PD, the D2 PET will be normal as compared to atypical PD. Okay, this also for dementia, also you have this how to approach, how to incorporate the nuclear medicine imaging. So same goes to movement disorder. You know when to incorporate your nuclear medicine imaging. So this actually a pragmatic approach on neuroimaging technique in the differential diagnosis of Parkinsonism. So on your left-hand side, you can see if patient present with Parkinsonian syndrome. So first thing, you must able to exclude all the symptomatic Parkinsonism, such as the vascular or space-occupying cause, before coming to the neurodegenerative Parkinsonism. So if the diagnosis is very clear, signs and symptoms are clear, then you diagnose patient with Parkinson's disease. However, along the way, as time progresses, patient might not responding well to medication, or the symptom or sign become unclear. So we can offer the presynaptic dopaminergic imaging. However, to further classify into MSA, PSP, or CBD, you need the FDG-PET-CT. Okay, this is another proposed clinical workup in the evaluation of subject with Parkinsonism. So you can divide into non-neurodegenerative and neurodegenerative by using of course, your clinical assessment is very important, and then you can also use the presynaptic dopaminergic imaging. But to differentiate between different types of Parkinsonian syndrome, you can use MIBG, FDG, or D2 receptor. So for example, this is a heart planar imaging using MIBG, which can differentiate PD, which do not show heart uptake. Okay? You can see that there is absent visualization of the heart as compared to atypical PD. Okay, these are the. Okay, I've shown you how the MIBG looks like, and then how the blood scan does now. So this is the FDG finding in movement disorder. So for example, we have different types of movement disorder. Okay, so our task is to basically to recognize how does this typical, how is this the diagnosis made by the differential characteristic of FDG finding. So like for example, in idiopathic PD usually shows normal finding, or there will be increase in metabolism in the thalamus, pons, and cerebellum. And sometimes, in some cases, they may also have bilateral parieto-occipital association cortex, which appear hypometabolic. Usually, that one will be they occur in late stage, whereby patient already develop Parkinson's disease with dementia. So that is another category of patient. Okay, they have both movement disorder as well as dementia. So for dementia of Lewy body is very characteristic. Just focus on the occipital, so there will be a hypometabolism of the occipital lobe, because other movement disorder won't cause hypometabolism of the occipital. All right. So for MSAP, usually there will be hypometabolism of the putamen. For PSP, look for the medial frontal region. Okay, dorsolateral frontal, caudate, as well as thalamus. So it will be hypometabolism. And for cortical basal dementia, usually the mark finding will be asymmetrical hypometabolism of the frontoparietal and also striatum. Okay, so this patient, a 68-year-old lady, our case as well, a case of right-sided hemiparkinsonism and hemidystonia, presented with right-sided hemipraxia, apraxia, severe dysarthria, and emotional disability for over 1 year. MMSE is fairly normal. The MRI showed frontoparietal lobe atrophic changes with predominant left hemicerebral atrophy and multifocal chronic lacuna infarct. Interestingly, our FDG showed asymmetrical. So the word there is asymmetrical hypometabolism of bilateral frontoparietal, more severe on the left, hypometabolism of the left temporal, precuneus, posterior cingulate, striatum, caudate, and thalamus. So because of this asymmetry, the diagnosis made was, based on the FDG, was cortical basal degeneration. So in conclusion, FDG PET is recommended to support the early diagnosis of Alzheimer's disease in MCI, early diagnosis of dementia with Lewy body, and frontotemporal lobe degeneration. FDG and amyloid tracer PET has a vital role in the assessment of patients with cognitive impairment and dementia, especially in those groups with atypical and mixed presentation, as the outcome of the scan has the therapeutic impact. So as I have shown earlier, most of my patients referred to us basically a young dementia, less than 65 years old. So the presynaptic dopaminergic transporter density has been shown to correlate with the density of dopaminergic neurons. Hence, the DART imaging is important to differentiate between the non-neurodegenerative ones and from the neurodegenerative Parkinsonian syndrome. And FDG PETs allow accurate differentiation between Parkinson's disease and the atypical one, which is of paramount therapeutic and prognostic importance. With that, I thank you.